So, Dr. Porter, welcome to the Cutting Edge. We're here at SAGES 2025. Obviously, your specialty is along the lines of common bile duct explorations, and historically, we've been passing that on to our gastroenterology colleagues, a lot of ERCPs, but you are now on the forefront of moving this more into a minimally invasive robotic approach.
Yeah.
Can you kind of walk me through what you're discussing here at SAGES, and then how that plays a role in the bigger picture of general surgery right now?
Yeah, this is obviously a passion project of mine. If I could give maybe a little primer for those who are not as familiar with common bile duct exploration, this is not new to the general surgeon. We were doing this open 100 years ago. It was really when there was the transition in the 80s to lap chole. The technology for the minimally invasive bile duct exploration was really rudimentary at that time. And so something that used to be a disease process that was really just managed by the surgeon intraoperatively suddenly became this 2 to 3 multi-procedural event, because ERCP had come around 15 years earlier and the technology was just so much more advanced at the time. So understandably, it just became this separate event, so much so that in 2013, only 3% of bile duct explorations were done laparoscopically. Everything else was ERCP at about 75, 80, and then a few were being done open. And so the question is, where does that bring us now in 2025? I think that's where someone like me kind of gets to come out into the field to really bring minimally invasive techniques that now the technology has caught up. The instruments are flexible. We have wire interventions, balloon interventions. I always say if you can do a central line, you could probably do a bile duct exploration. And then for me personally, where does that come into play? I actually was just very, very lucky. I got to train under Dr. Santos, who does a lot of minimally invasive common bile duct exploration work here through SAGES, actually. I got really lucky and I got to train under him at Dartmouth. And I think as a trainee, I underappreciated or undervalued having that training from him. He didn't just train us how to do a procedure, he trained us how to think and how to think about what's right for the patient and right for community and society in general. Not everywhere is going to have access to ERCP. And so lo and behold, when I went out into the real world and I became an attending, I worked at a hospital. Even though we're a busy level 1 trauma center, we're community and we have intermittent ERCP access. And so suddenly this problem where in training I didn't think twice about it, suddenly patients were being transferred out, they were waiting a week in the hospital, they were having multiple procedures for something that I knew I could do in a single stage surgery first approach. But I personally was switching to a full practice robotic. And at that time, there was nothing out there for educational material on how to execute this, at least in a transcystic fashion. I think a lot of HPB specialists will open the common bile duct or do a transcholedochotomy. But the minimally invasive, truly safe, reliable through the cystic duct technique wasn't out there. So shameless plug, that's what led to me figuring out and then actually starting a YouTube channel with educational materials through the help and support of SAGES with Dr. Santos. He pulled me on board to, have you heard of ADOPT?
No.
Okay, so ADOPT is the framework that SAGES uses to do adult learning, where you don't just, once you learn a skill, you go out and you do that surgery. No, you're gonna learn how to build a program. How do you have that conversation with the C-suite and convince them that this is the right thing for the patient, also the right thing financially, for the hospital. It teaches you how to build a cart, how to build a team, and then execute that surgery over a year-long mentorship program. So that's the ADOPT model, and then they came up with the ADOPT Minimally Invasive Common Bile Duct Exploration course. And so I went out into practice. I wanted to switch my practice to robotic. Dr. Santos was like, why don't you go through the experience of taking the course? So I took the course first, actually, which was very enlightening and helpful for me to upgrade my practice to robotic bile duct explorations. And then the next year I was invited to be faculty, so I got to kind of see how the whole thing works. And then this year I was invited to be a co-chair with him and actually running for the first time the robotic track. So we actually had the course yesterday. I think it went really, really well. And then the key thing is it's a year-long mentorship. So now every month they'll have check-ins. They can call us when they have cases.
A whole lot there that you just explained.
Yeah.
No, it's great. It's
I
amazing.
could talk about this for too long.
And that's what you're here for.
Yeah.
So, but I want to go back to the ADOPT. When you went through it, what does that look like to go through this process?
So you first start with doing pre-course work. So usually it's going through modules that have been made through other, like the government, like the VA has a module set that you can go through, and then SAGES, we've actually come up with several modules so you can learn about this. Then you do a 3-hour pre-course webinar where you learn all about safe cholecystectomy, IOC, what is a common bile duct exploration, what to expect during the course, and a little bit of a primer to get people excited. Then you come physically to the to SAGES and you take the course. We actually had it this time in the conference, which was great, right? It's much easier than having to leave for a lab. And you do 4 to 5 hours of hands-on, intensive, like one-on-one or two-on-one training of how to do the actual like physical technique. And then for the rest of the year, it's the turning the theory into practice. We have monthly webinars where everyone on the course, including faculty, all log in together. We go over one topic, but then we always have someone sign up and present their case, or present, maybe you're just at the point you're doing an intraoperative cholangiogram and you're not ready yet to take on the bile duct. That's okay. Present the case. Tell us what your difficulties were. Was your difficulty technical, or was your difficulty getting the OR to give you access to that equipment? Was it the C-suite? And we just work it out, and it's over and over again throughout the year. So,
where have you seen the most pushback in this field?
in terms of executing it, or in terms of teaching it?
Either case.
Okay.
Like, kind of walk me through, because I have to assume, ERCPs, of course, have been the standard for so long, and you're basically saying, let's go back. And I do think that that's something we need to remember is, as technology advances, what at some time was not the best option may come back around to be a very viable option again. I think that's what you're proving here. But what have the, we'll say the antis, or the not so happy about this?
The non-believers?
Yeah, what are the non-believers
who are not taking the common bile duct back?
Yes.
Taking it back. I would say in 2025, we get far less pushback than I saw maybe 5-10 years ago when I was learning the technique and becoming exposed to the data and research on it. The common theme is GI going to be upset, right? Like, are we taking away their referral pattern and taking away, I hate to say it, but taking away business? I certainly had that fear. And to my own surprise at my own hospital, when I reached out to them and said, hey, this is something that I can offer to patients, and got their input, it actually was interesting to find out that they don't actually want some of these consults, because over 70% of stones that are diagnosed or predicted, let's say, because we don't actually know if they're diagnosed, that's a whole nother conversation I can go on for days about, but predicted stones, you go to an ERCP before surgery, 70% either they're not there, or it's something very minor that we could have treated during an IOC. That's not high RVU production for a GI specialist, right? So instead, it's incurring incredibly high risk to a patient, another anesthetic event, doing interventions that can lead to major complications and death. It's not benign to get an ERCP. I think the endoscopists, because of that huge shift for the last 30 years, it kind of went too far, where they were getting all these consults that were unnecessary. It's a lot of burden on them to do the consult, right? Most hospitals, there's not a GI service. They're a consultant, and that's how it is at my shop. And so GI has to go to the ER, see the patient, write a note, follow them. That's a lot of throughput and work. I took that burden off of them, and I think that's where I pulled them in and kind of got that argument to go away, because now we're a bile duct service. You consult my team surgery first. We typically admit you, and then we decide where you're more appropriate to go, because not every patient should have a common bile duct exploration, right? For me, you have to have a gallbladder. For me, before I had lithotripsy, you have to have a stone smaller than a centimeter. There might be a hostile abdomen situation, and then we need multidisciplinary support. You need IR and GI to be doing retrograde access, rendezvous access. So that was one major, I think, talking point against it that I think now we've settled. I think another common misconception is that it might be unsafe, or perhaps because you're not an HPB specialist, that this is maybe not appropriate to be doing for patients. I would argue against that. I'm an acute care trauma surgeon. I am not HPB specifically trained. I feel I had good training. But the way that we do this, it's transcystic. It's all over a wire. It's all Seldinger technique. Again, if you can do a central line, you can probably do what we do. And I think if you do it in a systematic fashion where you're very thoughtful in your selection of the patient, and then you pay attention to your own outcomes, you come to conferences, you join webinars, and you stay up to date on the possible risks and things to look out for, you can be very safe and execute this. Obviously, I'm biased, it's myself, but I don't consider myself to be some savant surgeon. I just am meticulous about a step up in risk to the patient with effectiveness. And so I have an algorithm where it's fluoroscopy first, and then only cholecystoscopy if that doesn't work. We push all stones forward. We have 95% success and almost no complications.
Imagine a platform that connects you directly to a private group of surgical colleagues. Within the app, you interact socially with colleagues, post your own surgical videos, scan the library for relevant content by type of surgical procedure, anatomy, or even specific operative step. You'll be invited to live webinars and build your network through conferences hosted on the app, all while maintaining your privacy. Surge On, where surgeons go to explore, discover, and learn.
I find it interesting. It's always that debate, like you're going into HPB in this case, but even when I was younger, I'm not that old. We were doing open common duct exploration. General surgeons were doing that, and that's
no one thought twice.
Yeah, nobody. I mean, it was because the generation that was in their prime at that time, they had grown up doing them, and that was your general surgery population. So it wasn't a HPB requirement kind of thing, and that's a much more invasive version of this than what we're talking about now. So I find it a little odd to now say that transcystic is this.
It's fascinating that now there's an argument for it. I think that happened too if you look at a different field like TAVRs, right? You have a lot of non-cardiac surgeons doing TAVRs now, and then we all have to sit back and question, is that appropriate too, right? Because if you perforate the septum or if you perforate the myocardium and now they have pericardial effusion and they need an emergent pericardial window, you have to consult someone else.
Yeah.
But I think that's part of innovation. That's part of giving access to hundreds of thousands, if not millions of patients to the benefits of minimally invasive are going to come with some price tags, and some of that is being really thoughtful and safe and knowing your limitations.
Let's also talk about the fact you're 3 years into practice, is that correct? So you're still in the front end of your career, and yet here you are at SAGES, one of the biggest society meetings in the country, and you're already at the level of professional, of expert, master in what you're doing. What does it feel like to move through the system so quickly? And to a new surgeon coming into the field, let's say right out of residency or fellowship, what should they be looking at from the societies or SAGES in particular?
I would say I'm still taken aback by even being put in the same sentence as the word expert. I don't consider myself an expert. Again, I feel like I was a very fortunate trainee to train under an expert, get that education, and then get pulled into the SAGES framework of teaching. And that's where I think this is why I'm drawn to this conference. I mean, your trauma and acute care, I don't think people would expect me to be like someone actively involved at SAGES, on committee meetings at SAGES. You would traditionally be East, West, AAST, stuff like that. But I find SAGES to be the most clinically relevant, innovative, and interesting conference that I go to, certainly as a trainee and now as a surgeon. And so I would say their motto is inclusivity. They want voices from every aspect of the field, including new grads who are bringing a very different perspective. Also, I came up in the kind of in between laparoscopic and rapid adoption of robotics, which I just went to, a session on talking about that comparison. I think you want to have our voices. You want to have people who are maybe on the non-traditional minimally invasive surgery platforms like trauma and acute care who are interested, showing up at the table. When I went to the committee meetings the other day, I mean, the range of people involved, you had medical students, you had trainees, you had new grads, you had mid-career, you had late career. Hearing everyone's perspective was enlightening. And that's, I think, for me, what's drawn me to SAGES and given me the opportunity to be able to sit with you. I mean, this is wild.
Our philosophy at Surgeon is very similar. We believe that, as I always tell people, I don't think there's any stupid surgeons out there. I think to get through the educational process, to do the testing, all that, like we're all intelligent. It's amazing breadth of talents throughout the surgical community, and we all kind of make our decisions as to where we're going to fit in society. Some communities, some academic, bigger practice, smaller practices, private practice, however you want to define it. And each one of us is bringing a different perspective, like how we're going to, the wisdom that we accumulate because of the perspective that we're looking at it from. And you're right, I think sitting at that table, it's probably fun to kind of hear all the different voices and how they look at the same problem. As you've been going through that process, what has been the most enlightening or eye-opening part of the experience?
I found very enlightening that there's a lot of redundant work going on. As a millennial and someone who's all about efficiency and just trying to make things, as efficient as possible, I found that there was so many groups that are trying to accomplish the same thing but not communicating with each other. And going to multiple different committee meetings. For example, I went to the acute care task force, I went to the safe cholecystectomy, and then I followed it with the robotics committee meeting, and every single one had the same concern that we're creating all this content, but if no one's watching it and they're not getting access to it, what is the point? And then we're making all the same content under little different umbrellas, but they're not together in one like collaborated fashion. I found it very interesting to watch meeting after meeting, people saying, well, I just heard this in the other room. Why aren't we all working together? And then watching the great minds at the table, literally just texting the other co-chair and collaborating, saying, you're right. We need to create one area, one collaboration of educational materials. So just watching that one tiny microcosm of what SAGES does of education and videos, just watching how a comment crossed over to another meeting, watching people connect in front of you as a new young, surgeon in the field, seeing how people are just connecting was enlightening.
I do think it's interesting. It's like the paradox of you want all these people, you want all these voices because you really need that perspective, but then at the same time as it gets bigger, then it's hard to manage all the voices and all the people and make sure that we're all kind of pointing in that same direction. In these meetings, where do you see the future of SAGES going?
I definitely think SAGES has a big opportunity with education and becoming a sanctioned resource for trainees, starting with medical students, getting people involved a lot earlier with creating a video atlas that's easily searchable and usable for the surgeon, creating an on-the-go access to education where it's 2 a.m. and you're in a community hospital and you don't have any other resources, and then this, perforated foregut that happens to be 3 centimeters shows up in your ER. You want to be able to just go to like a quick resource that gives you everything comprehensively right there on the go learning. I see SAGES blowing up on that front in terms of innovation with just interactive interfaces for education. I think they're going to make a lot of strides right now in the robotic boom, and with all the new potentially products coming out, I think they're going to have a big voice at the table on that, and I think that's where we all want to be at the table. And just to put out a disclaimer, again, like I know I'm a very new young surgeon, I'm not sure my role yet is to necessarily be a constant voice, but my role is to watch, observe, see how they make changes so that if and when I'm ready to come up, I can do the same and not make the same mistakes.
And when you're talking to your residents or your trainees, what would you say is that piece of wisdom you've learned, even in a relatively short career so far, but even then, what is that piece of wisdom that you've learned from your practice that you wouldn't necessarily find in any textbook?
To be humble and to not ever put yourself in a situation where you have no support. You may feel small, you may feel alone at 3 a.m. Someone's been through what you've been through, and there are some unbelievable resources. Surgeon, for me, has been an unbelievable explosion of resources, mentorship, sharing and collaboration. Maybe I don't have a big tumor board at my hospital, but I can put up a video 2 weeks before I'm seeing that patient in clinic, or they show up in the ER, I've got a few days to plan their surgery, and get people's thoughts. Feel comfortable reaching out to a previous attending that you had or mentor. I mean, like, hey, I might call you in a month because I know you've done trauma and acute care now for a long time, and I might have some wild gunshot wound where I'm not sure how to reconstruct. I might call you, and just so understand that this is a very small community, we all want to support each other, and no one's going to judge you, and just take resources where they come to you.
Oh yeah, obviously we're huge fans of that philosophy.
Yeah.
We think that there's no reason to bully each other, there's no reason to be mean. Like, we're all trying to just help patients get through the day.
John. It's like a safe space.
Oh yeah, no, it's very much, we want to make sure that we're able to have those open conversations that you just really can't have elsewhere. Mm-hmm. And I think that you've been obviously a fabulous resource as well, and so let's not downplay that fact. The reason you're here is because we love you on the platform, and we think that what you're doing is just amazing, obviously. And to be moving through the system as quick as you are, it's well-deserved, obviously. So we truly appreciate your time.
Thank you.
And once again, thank you for coming to the Cutting Edge. I hope you enjoy the rest of your time here at SAGES, and we look forward to hearing from you in the future.
Well, thank you.
Thank you.
Okay.
Thanks, that's great. You did fabulous.